In this module, we will review the basics of probe manipulation and also explore how to obtain each echocardiographic view using simulated images to assist in understanding the probe position. This module will serve to solidify your understanding of these complicated and important concepts. There are a number of challenges in obtaining high-quality TEE images of the heart. The position of the body may make imaging difficult if the patient is not in a standard supine position. Prone or lateral positioning, for example, can make the process very challenging. The esophagus provides an excellent conduit for allowing the probe proximity to the heart and other structures of interest, but at times restricts the ability of the user to align the probe with the axis of the heart desired. The heart may be rotated in the chest and does not conform to standard anatomical planes, making probe positions and scan plane rotations more guidelines than gospel. Mastering these combinations and the subtle adjustments required to optimize image viewing can be extremely challenging. Finally, taking a two-dimensional image representation and extrapolating information on cardiac function and structure can be extremely challenging and requires a thorough understanding of anatomy and physiology. Here we see the many different positions which a transthoracic echo probe can be positioned in to align it with the differing axes of the heart. By contrast, a TEE probe can only advance via the stomach and esophagus, and thus has a more limited range of positions from which to image the heart. On the left, note the standard anatomical planes and the associated terms. On the right, we see the heart does not lie in an anatomic plane, but rather passes through several planes in its standard orientation in the chest. Thus, anatomic terms such as superior, inferior, anterior, and posterior cannot be easily applied to describe orientation of structures within the heart itself. The esophagus both provides a conduit to allow close imaging of the heart and also provides limitations to the positions the probe can achieve in relation to the heart. This is further complicated by the fact that some structures of interest, such as the aorta, do not run completely parallel to the esophagus throughout their course. Furthermore, the left main stem bronchus becomes interposed between the aorta and esophagus in the aortic arch. Since it is filled with air which conducts ultrasound poorly, it is difficult to visualize the proximal aortic arch and impossible to visualize the distal ascending aorta with TEE. The standard four-chamber view is seen here with the probe orientation in the mid-esophagus. Note the direction that the ultrasound waves leave the probe and pass through the heart. This is the sector that appears on the screen during imaging. We have already evaluated the relationship of the aorta to the esophagus, so we will now turn our attention to the relative position of the heart. The heart lies in a position in the chest which is just to the left of midline and angles anteriorly and inferiorly from base to apex. The right atria and ventricle are on the patient's right, which is on the left on the slide. Just as with the aorta, the heart does not follow the esophagus in a way that is linear or easily definable, and thus images must be obtained by rotating the probe and adjusting the multiplane angle. The orientation of the heart on a standard TEE is intended to give the viewer the surgical view of the heart. As in this image, the attending surgeon typically stands to the patient's right and peers into the chest cavity from this orientation. Needless to say, several manipulations have to be made to the image acquired from the esophagus to achieve this standard orientation. From the perspective of the echo probe, the left atrium would be at the bottom left of the screen, whereas in the displayed image it would be at the top right of the screen. The image must therefore first be flipped top to bottom. Next, it is rotated left to right so that the left atrium is at the top right of the screen and the right atrium and ventricle are at the left of the screen. To reinforce, the image is flipped and rotated left to right from what is initially acquired. This is a standard convention in most centers. We will now examine the standard omniplane angles used to aid in imaging the heart, while using a clock face to help us orient the position. The 0-degree scan plane would cut the clock face across from 9 to 3. With image flip and rotation as described previously, the 9 side will appear to the left of the screen and the 3 side to the right. Note the omniplane angle that appears on the screen with the echo image. It shows a semicircle with a dial, which sweeps to represent the degree selected between 0 on the left and 180 on the right. In this case, the probe is at 0 degrees, so the dial points all the way to the left. At an omniplane angle of 60 degrees, the plane would exist between 7 and 1 on the clock face. On the display, 7 would be to the left and the 1 to the right. The omniplane angle of 60 degrees would place the dial at a 60-degree angle, 2/3 of the way between 0 and 90 degrees. At an omniplane angle of 90 degrees, the plane would exist between 12 and 6 on the clock face. On the display, 6 would be to the left and 12 to the right. The omniplane angle of 90 degrees would place the dial perpendicular or at midpoint of the semicircle. At an omniplane angle of 120 degrees, the plane would exist between 5 and 11 on the clock face. On the display, 5 would be to the left and 11 to the right. The omniplane angle of 120 degrees would place the dial at a 120-degree angle, 1/3 of the way between 90 and 180 degrees. This image demonstrates the rotation of the omniplane angle from 0 to 120 degrees. You can see that systematically using this set of 5 angles will result in coverage of the entire clock face, and thus of the heart that it represents. The standard views for a comprehensive intraoperative transesophageal echocardiographic exam were defined by the American Society of Echocardiography and the Society of Cardiovascular Anesthesiologists in a position paper authored by Shan Wise and colleagues as a joint task force. The position paper defines the comprehensive exam views and describes them in terms of probe positions and crystal rotations. The views can be acquired at 4 cardinal probe positions in the stomach and esophagus. The probe can be advanced from the upper esophagus through the mid-esophagus and into the transgastric and deep transgastric views to achieve a variety of images. The changes in depth, combined with the rotations of the crystal through a range of angles, allow complete visualization of cardiac structures. The images that follow will describe the standard exam in detail and references their standard depths and angles unless otherwise noted. The HeartWorks simulator is used in the following slides to show an idealized TEE image alongside of an anatomic representation. The mid-esophageal 4-chamber view is obtained between 0 and 20 degrees at a depth of approximately 30 to 40 centimeters. This view shows both atria, both ventricles, and the mitral and tricuspid valves. Sometimes, the aortic valve can also be visualized in the center of the screen in what is referred to as a 5-chamber view. Remember that the anterior leaflet of the mitral valve is always in close association with the aortic valve. Thus, the left leaflet in this image is therefore the anterior leaflet, while the right leaflet is the posterior leaflet. This relationship will change as the probe is rotated. The four-chamber view is a reasonable way to show the viewer an overview of the heart early in the exam. Here we see the mid-esophageal four-chamber view presented from another angle, as though we were looking from the surgical field. Note the line drawing in the anatomic image that shows the location of the probe in the mid-esophagus. Also, notice the probe depth indicator in the right window, which shows the probe at a depth of 35 centimeters. The omniplane angle in this image is at 0 degrees. In this side-by-side comparison, you can clearly see the structures of the right side on the left of the screen and those of the left side to the right. Note the thicker wall of the left ventricle, the thin walls of the atria, and the chordae and the tricuspid and mitral valves. The walls of the left ventricle seen here are the septal wall in the middle and the lateral wall to the right of the screen. The mid-esophageal mitral valve commissural view is seen at the same depth of 30 to 40 centimeters at an omniplane angle of around 60 degrees. The left atrium and ventricle are visible in this view. Here, the mitral valve takes on a classic seagull appearance with the P1 to the left, A2 in the middle, and P3 on the right. This characteristic configuration aids in the assessment of mitral valve leaflet pathologies. We again see the commissural view from the mid-esophagus at 35 centimeters and 60 to 70 degrees. Note the support structures of the mitral valve, the thin chordae tendineae, and the thick papillary muscles, which are well seen here. Some patience and fine adjustment is often necessary to bring this view into focus and see good separation of the leaflets. These fine movements include antiflexion, retroflexion, clockwise and counterclockwise rotation of the probe. This slide demonstrates the mid-esophageal two-chamber view at 90 degrees. This view is again obtained at a 30 to 40 centimeter depth by rotating the omniplane angle to 90 degrees. Retroflexion of the probe is often required to prevent foreshortening of the ventricle. Note on the schematic the presence of the left atrial appendage to the right of the screen. While characteristic, it is sometimes difficult to see clearly in the same imaging plane as the ventricular walls. Further inspection of the mid-esophageal two-chamber view can help identify some key relationships of intracardiac structures. The posterior mitral leaflet is to the left in this image, while the anterior mitral leaflet is to the right in this image. This can be remembered by realizing that the left atrial appendage, also to the right of the screen, is an anterior structure. Note on the simulated ultrasound image the small circular blood-filled structure to the left of the posterior mitral valve leaflet. This is the coronary sinus, which runs between the atrium and ventricle and returns deoxygenated coronary blood to the right atrium. The left ventricular walls, seen on the two-chamber view, are the anterior wall to the right of the screen and inferior wall to the left. Rotating the omniplane angle out further to between 120 and 160 degrees in the mid-esophagus yields a long-axis view of the aortic valve. In addition to the valve, the left ventricular outflow tract and aortic root can be seen in continuity on either side of the valve. This is the view which is used to measure the left ventricular outflow tract for use in calculations of aortic valve area or cardiac output, which will be addressed both in the hemodynamics modules and the aortic valve modules more fully. The left atrium, mitral valve, left ventricle, and typically part of the pulmonary artery can also be visualized in this view. Observing the HeartWorks model allows us to see in a beating virtual heart the close proximity of the mitral and aortic valve. One key relationship which should be noted is that of the anterior leaflet of the mitral valve to the aortic valve and left ventricular outflow tract, or LVOT. This is the leaflet that can obstruct the left ventricular outflow tract in systolic anterior motion, or SAM. The walls of the left ventricle seen here are the anteroseptal, adjacent to the aorta, and the inferolateral wall opposite, on the left of the screen. Because wall motion and function of both the mitral and aortic valves can be seen in this view, it represents a useful view when weaning from bypass after mitral or aortic valve surgery. The mid-esophageal bicaval view is seen at a 120-degree omniplane angle in the mid-esophagus. It is in the mid-esophagus at a 30 to 40 centimeter depth. It requires clockwise rotation of the probe from a 4-chamber or aortic valve long axis view. In this view, you see the superior vena cava to the right and the inferior vena cava, and often the coronary sinus, to the left. The right atrium is the large chamber connecting the two caval structures. The intra-atrial septum can be seen between the left atrium at the top portion of the screen and the right atrium at the lower portion of the screen. This is an ideal view to interrogate the septum for an atrial septal defect or patent foramen ovale. It is also a useful view to observe the J-wire advancing into the right atrium when a central line is placed. In this beating heart bicaval view, we can see the tricuspid valve and part of the right ventricle appearing intermittently in the lower portion of the screen. With some adjustments, this view can thus be useful for interrogating the tricuspid valve for regurgitation or stenosis, or aligning a Doppler signal for evaluating a tricuspid regurgitation gradient for the purposes of estimating pulmonary artery systolic pressures. This concept will be covered more thoroughly in the hemodynamic and right heart modules. As with other mid-esophageal views, the mid-esophageal aortic valve short axis view is seen at a depth of 30 to 40 centimeters. From a 4-chamber view, the omniplane angle is rotated to between 30 and 60 degrees while focusing on the septum. The aortic valve appears in the center of the screen as a tri-leaflet structure with a classic Mercedes-Benz appearance. If the leaflets are not symmetrical or do not appear to coapt evenly, the probe should be advanced or withdrawn until the plane of coaptation is readily apparent. This is a useful view to evaluate for aortic insufficiency by placing color flow across the valve. It is also a helpful view to assess aortic stenosis through planimetry, which involves tracing the valve opening at its maximum. More information will be presented in the aortic valve modules. Other cardiac structures typically visible in the mid-esophageal aortic valve short axis view include the right atrium, tricuspid valve, right ventricle, and the pulmonary artery. The left atrium is also visible adjacent to the right atrium, and thus the interatrial septum is also seen. The mid-esophageal RV inflow-outflow view is seen best at an omniplane angle of 60 to 90 degrees. It is often visible by simply advancing 1 to 2 centimeters past the depth of the mid-esophageal aortic valve short axis view and rotating the probe slightly clockwise. This view demonstrates the structure of not only the aortic valve, but also the tricuspid and pulmonic valves. As the name inflow-outflow implies, the echocardiographer can trace the flow of blood from the right atrium through the right ventricle and into the pulmonary artery in this view. It is a helpful view in positioning of a pulmonary artery catheter for this reason. While the beating heart model here shows the pulmonic valve quite clearly, it is often poorly seen. In cases where the valve is difficult to locate, placing a color flow sector below the right coronary cusp of the aortic valve can often demonstrate any evidence of pulmonic insufficiency and therefore be useful in locating the valve. The left atrium can also be seen at the top of the inflow-outflow image field. The transgastric mid-papillary short axis view is obtained by advancing the probe into the stomach to between 40 and 45 centimeters in depth. The probe is then antiflexed gently to develop a plane through the short axis of the ventricles. The mid-papillary short axis view is critical for evaluating wall motion and volume status. It shows walls which are perfused by all of the main coronary arteries in the same view, and thus can give a sense of what territory may be ischemic. More details will be discussed in the module on left ventricular wall motion. In order to be deemed a mid-papillary view, both the anterolateral and posteromedial papillary muscles should be visualized in the scan plane. In terms of cardinal relationships, remember that the septum sits between the right and left ventricles. The lateral wall is always across from the septum. Notice that the echo probe, despite sitting behind the heart in the esophagus, is always positioned at the top of the echo screen. Thus, the inferior wall is at the top of the echo image, while the anterior wall is at the bottom. Understanding these relationships will help you to define all 6 walls, since the remaining 2 walls are defined by their orientation to these 4. The anteroseptal wall, therefore, is between the anterior and septal walls, while the inferolateral wall is between the inferior and lateral walls. In addition to wall motion and volume status, wall thickness can also be measured on this view to assess for hypertrophy. To the left of the screen, the right ventricle can be seen alongside of the left ventricle. In the normal state, it should appear smaller and crescent-shaped. Codominance of the right ventricle would suggest significant dilation and require further assessment for pulmonary hypertension, a septal defect, stenotic pulmonary valve, or congenital anomalies. Because of its irregular shape, the right ventricle is only defined in terms of the septal and free walls. The transgastric basal short axis view is obtained by either increasing probe antiflexion from the mid-papillary view or withdrawing the probe slightly from a mid-papillary view and antiflexing. The goal is to see the characteristic fish mouth appearance of the mitral valve, along with the basal walls of the left ventricle. Wall motion of the basal segments can be assessed here. Color Doppler can also be applied to identify the segments of the mitral valve involved in mitral regurgitation. A portion of the basal right ventricle and tricuspid valve are often also visible in this view. In this video, you can see clearly the relationship of the probe to the heart in the basal view. Note the papillary muscles, which can be seen just below the valve on the animated anatomic view. The aortic valve at times appears partially in the view in this case. It is not uncommon to have some contamination of this view with the appearance of the LVOT and/or the aortic valve at the anterior septum, making wall motion challenging to assess in this portion of the base. The transgastric long axis view is obtained by rotating the probe 90 to 120 degrees from a mid-papillary short axis view. Like the mid-papillary view, the probe depth is between 40 and 45 centimeters in most patients. This view shows the anterior wall of the left ventricle running longitudinally near the bottom of the screen, with the apex to the left and base to the right. At the far right of the screen, the mitral valve and, below it, the aortic valve can be seen. This view can be used to obtain gradients across the aortic outflow tract and aortic valve for use in hemodynamic calculations. In tracing the evolution of the long axis view as the probe is rotated from 0 to 90 degrees, this video helps to orient you to the position of the probe in relationship to the heart. It also demonstrates the ability to evaluate the papillary muscles, chordae, and subvalvular structure of the mitral valve. After aortic valve replacements, there are often artifacts in the mid-esophageal views that limit the ability to see the valve adequately, so this view should be obtained to assist in evaluation as well. Note that while not shown here, the transgastric two-chamber view can be attained by rotating the crystal slightly back to between 80 and 100 degrees. This view shows the left ventricular walls, mitral valve and support structures, and left atrium, and can be a useful adjunct for wall motion assessment. Clockwise rotation of the probe from a transgastric long axis view yields a transgastric RV inflow view. This view can alternately be obtained from a mid-papillary view by rotating the probe clockwise until the right ventricle is in the center of the imaging sector, and then rotating the omniplane angle to between 100 and 120 degrees. Similar to the LV transgastric view, the apex of the right ventricle will be to the left of the screen, and the base will appear to the right. The transgastric right ventricle inflow view shows the septal and free walls of the right ventricle, and is particularly useful for assessing the inferior free wall of the right ventricle. The tricuspid valve and its support apparatus can also be assessed here. Advancing the probe slightly deeper from the transgastric viewing depth and antiflexing the probe results in the deep transgastric view. It is typically achieved at between 45 and 50 centimeters in depth. In this view, the apex of the left ventricle appears at the top of the screen while the base is at the bottom. The left ventricular outflow tract, aortic valve, and proximal ascending aorta appear at the center of the bottom of the screen in an ideal position to align a Doppler beam for uses in hemodynamic measurements. This video begins with the probe advancing into the deep transgastric depth at 45 to 50 centimeters. First, the LV apex is seen. Then, the probe is antiflexed to show the structures of interest. This view requires a considerable amount of practice to obtain consistently. If it cannot be obtained in a patient, the transgastric LV long axis view can be used to obtain similar hemodynamic data. The following slides will deal with the assessment of the aorta, which must be assessed throughout its course and thus is imaged at a variety of depths. Slightly withdrawing the probe from the mid-esophageal aortic valve short axis view will result in a view of the ascending aorta in short axis. This view can alternately be developed by rotating to an orthogonal view from the ascending aortic long axis view, that is, rotating 90 degrees from the aortic long axis view. This view is usually at an omniplane angle of between 0 and 60 degrees. The ascending aorta appears as a large central circular structure in this image. The superior vena cava appears as a smaller circle in the 9 o'clock position. The main pulmonary artery classically can be seen arising near 5 o'clock. It branches, and the right main PA can be seen above the ascending aorta and superior vena cava, while the left main PA usually is not in the field of view. This video shows an exceptionally clear view of the structures noted earlier, plus a portion of the left main pulmonary artery after the PA branch, which is rarely seen in adult patients in vivo. The ascending aorta can easily be measured in this view, as can the main pulmonary artery. This view is also useful for optimizing the positioning of a pulmonary artery catheter, which should terminate just inside the right main PA. The mid-esophageal ascending aortic long axis view is obtained at 30 to 40 centimeters in depth. It is best developed by first obtaining an aortic valve long axis view between 100 and 150 degrees and slowly withdrawing the probe while keeping the aortic contours in a parallel orientation to each other by making slight adjustments clockwise and counterclockwise with the probe. This view allows for visualization of the proximal portion of the ascending aorta above the aortic root. It is usually interrupted abruptly by degradation of the image due to the passage of the left main stem bronchus between the esophagus and the aorta at the mid-ascending level. Unfortunately, the level where the view of the aorta becomes obscured is the critical place where the cross clamp and aortic cannula are typically placed. Epi-aortic scanning can remedy this deficiency of TEE. The video demonstrates the imaging plane obtained, but shows more of the ascending aorta than can typically be visualized in vivo. Notice the right main pulmonary artery as it passes underneath the aorta. It appears as the circular blood-filled structure above the ascending aorta on the TEE image in this view. By withdrawing the probe to 20 to 25 centimeters and rotating the probe, the upper esophageal views are obtained. At 0 degrees, the long axis view is visible. It should be inspected for dissections or luminal irregularities. The transition from the arch to the descending thoracic aorta is the point at which the left subclavian artery takeoff appears. Rotating the probe to 90 degrees from the upper esophageal long axis view of the aorta yields the short axis, which is seen as a circular structure. Measurements can be obtained and inspection for dissection flaps or plaques conducted. Note that the short axis of the arch appears remarkably similar to the long axis of the descending aorta, but at a lower depth and a different omniplane angle. While the HeartWorks simulator is not equipped to provide imaging of the thoracic aorta, this can easily be obtained in vivo by advancing the probe from the arch position or rotating the probe from the mid-esophagus. Imaging should be done at a scan depth of around 7 centimeters and conducted throughout the length of the aorta until it disappears from view around the level of the diaphragm. At 0 degrees, the short axis is seen as a circle, whereas at 90 degrees, the aorta appears as a tubular structure. This is precisely opposite to the angles for imaging the aortic arch. The aorta is not strictly adherent to the esophagus, and so the relationship of the two structures changes throughout the course. It is not uncommon to transiently lose imaging of the ascending aorta as the probe is withdrawn through the mid-esophagus near the level of the left atrium for this reason. In summary, the intraoperative TEE exam is conducted through careful combination of probe positions and crystal rotations. Remember the 4 cardinal probe positions and the typical crystal rotations, and employ them in combination to achieve a comprehensive echocardiographic exam. While daunting at first, with practice in the simulator lab and OR, you will soon become an expert in this valuable imaging modality.